Welcome to this RCGP webinar on QOF quality improvement, and it's entitled Maximising Involvement of the General Practice Team. My name is Mike Jones. I'm a GP and I work mainly in East London, and I'm one of the RCGP's National Clinical Quality Improvement Champions. So you'll definitely be familiar with QOF from the point of view of your day job in general practice, but we're here today to talk about QI improvement in QOF specifically, and to provide you with an overview of some core concepts and principles, and to bring these to life with some clinical examples, and to look at how you can continuously improve the experience of both yourself, your staff, and importantly, your patients. So what can you expect to take away from this evening? Well, we'll be addressing the many benefits of QI. We'll address some simple tools to support your progress. We challenge you to think about how to embed a culture of continuous quality improvement in your practice. In terms of learning objectives, because they're crucial, we will look at how to get up and go by making a start on this work, and how to set up a QI project team. We'll look at how to create smart aims and to work out measurement criteria, and to establish what does success actually look like. And we'll look at some QI tools that you probably already use, and try to understand some others which you may not, which can help. And finally, how to sustain new practice and new improvements. And we'll try to bring the concepts and the principles to life with examples from the floor. So always some housekeeping, and before I introduce my panel, I need to cover these few things. So we'd like to make a video recording of this webinar available to those who are unable to attend tonight but did sign up. So we're going to focus on the slides and the presentation in the first half. I'm going to hold a question and answer session in approximately the second half. If you've got a question, please do send it to us using the Q&A option on Zoom right at the bottom of your screen. We have disabled the chat function so we can ensure that we can better moderate the questions coming in, but we haven't disabled the hands up function, but we're not going to use it tonight, as we want to ensure the focus is on presenting the content and allowing things to flow. So we'll stick to time, we promise. If we do run out of time and we can't answer all of your questions, we will endeavour to follow up with you offline. And generally what we do is we generally compile all the questions and answers and send them to everybody involved, even if you didn't ask one. So please do send them questions throughout the presentations, and we'll pick them up later. So hopefully by now you'll know what QOF is, and you'll know what QOF quality improvement is, but I'll just give you a wee overrun here. So this year's modules concentrate on the early diagnosis of cancer and the screening element of cancer, and care of people with learning disabilities. But tonight we also focus on the programme of work that's been delivered by the RCGP, funded by NHS England and Improvement over the last 2 years. And this has been in collaboration with experts from a number of different organisations, including the Health Foundation, NICE, and also Hull York Medical School. So we produced 10 QOF QI modules and all of the accompanying resources to go with them. This year we've been busy producing materials to support this year's modules and next year's, and also more general guidance on how to carry out quality improvement projects, how to approach QI, and how to use QI at PCN level. So there are webinars and podcasts on these subjects already on the RCGP website. For more information, do visit the links on the screen, and we can share slides after the webinar, so you have those links and other links as well. Finally, if you are on Twitter, you can find us holding Twitter chats and promoting resources by searching for hashtag QOF QI and at RCGP. So now we've covered the housekeeping, I'm going to ask both Liz and Lorna to introduce themselves before we take you through the presentation. So starting with Liz.
Hello, it's lovely to be here with you tonight. I work as a senior lecturer at Hull York Medical School in improvement science. So I'm really excited to be here with you tonight. Part of my job is training both physician associates and medical students to be able to get confident and capable in their quality improvement skills, particularly to support primary care initiatives. The other part of my experience relates to working for the Cochrane Effective Professional Practice Group as well, and how we evaluate effective interventions that might be more likely to be successful. And so we'll go on to share some of those with you tonight, as well as some examples of what we've learned from our development in primary care quality improvement. So I'll pass on to Lorna next.
Hi, I'm Lorna Laughlin. I'm a practice manager in Preston, Lancashire. I also work for the RCGP on the primary care development team, and recently have joined the Greater Manchester GP Excellence team. I think I'm on this webinar more for my lived experience of QI in general practice. Certainly don't claim to be an expert of any kind, but hopefully can maybe give people some ideas on how you can start to introduce QI in your workplace and the different team members that can help you with that. Thanks, Mike.
Absolutely, Lorna, absolutely. So hopefully we've got all bases covered, and hopefully we'll be able to field and tackle any questions you've got. So as we say, do pop them in Q&A at any point, don't wait till right till the end. What would be really helpful actually for us, because we have 150 odd people signed up already, but we're not quite sure what everybody does. It wasn't asked before we started. So if you wouldn't mind just popping that in the Q&A section, you won't all be able to see each other's answers, but we'll be able to sort of find out in the background. Just tell us what your role is in the practice, please. Are you a physio? Are you a student? Are you a PM? Are you a nurse? Are you a doctor? And it'd be helpful for me to know as we go along. Okay, thank you. So a little bit of context is always helpful. I'm sure you probably fully already empathize, you agree with what's written on that slide there. So pre-COVID-19, there were already loads of issues making it really difficult to deliver improvement, including high patient demand and staff shortages. There was loads of demands from other NHS agencies and other NHS services, lack of protected time, lack of improvement capability. There is a very long list. And so when COVID happened, patient demand temporarily dropped, but then it's gone and rebounded beyond pre-COVID levels. So for the last 20 months or so, nearly all practices have tried to grapple with various new challenges, including telephone and electronic triage systems. Practices have needed to make changes, and quickly. And most have managed to adapt really well and successfully in the face of workforce illness and increased demand. So in addition, practices and PCNs also devoted their time to an unprecedented massive vaccination efforts, many started from scratch. So without labeling that work formally as quality improvement, which it is, practices have been maintaining or improving quality in the face of adversity solidly for the last 20 months out of sheer necessity, and at an extremely rapid pace that we previously thought imaginable. So what can quality improvement do for your practice? What can it do for your patients? Next slide, please. Thank you. So QI provides flexibility. It provides the ability to tailor improvements or changes to your specific practice population. So you compare that to the way that the remainder of QOF works, with its various lists and registers, and some would say tick boxes, which has proven to have positive outcomes in lots of areas, but it's relatively formulaic, whereas quality improvement does allow a little bit of, lots of ingenuity, a lot of flair, ability to really focus on your patients. So practice, because of COVID, obviously QOF and QI were suspended along with a variety of leses and the likes. But many practices had already started making inroads into either or both the cancer or the learning disability improvement domains. So, and then feedback from practices from 2 years ago, when we dealt with the prescribing safety and when we dealt with the end-of-life care modules, feedback was wide-ranging and had lots of positives. So just picking some of the beneficial ones, just in case you weren't aware of how other sites were doing. There was an agreement that many of the processes felt safer and more robust as a result of what had been implemented. There was, amongst some sites, a shared sense of satisfaction once their systems had been shored up. Many practices were really candid and said they were surprised at their own baseline performances because they weren't really aware of where to look for various baselines. And so that actually led to determination to improve things just from a different angle. Also, I think improving equity and improving, I suppose, voices from some staff members. So some quieter members of staff actually reported feeling better able to contribute to their team. They felt a little bit more included. They felt like they were heard a bit more. And I think, as we all know, we've all been involved in practice meetings where often one or two voices can dominate. So QI was a good vehicle for that. And we haven't done a follow-up from that to see how that's gone and benefited in the long term. But for me, that's a really good aspect of it. There was some enjoyment regarding the learning new skills, but others generally appreciated the ability to collaborate and being incentivized to collaborate with their local practices and their local PCNs, some of which they'd never spoken to, some of which they'd elected not to speak to, but were forced to, but actually found it beneficial. So all of these I just mentioned link in with what's known as the triple aim of healthcare. I will make this really brief. You may have seen this, you may not have seen this, but it was coined by the Institute of Healthcare Improvement in Boston in America. But these three tenets are global, they're kind of worldwide. And it's basically a framework approaching how to improve the health of the population. So the ideal is that we can both, we can improve the experience of patient care whilst also improving their health and also providing value for money. Now, in many instances, you'd think that at least one or both of those are compromised. So this is the aim, the triple aim. And there are some local adaptations to this. So some people have converted it to a quadruple aim. And the fourth aim some people think about is trying to experience joy in work or trying to have joy at work, which wouldn't be pretty great, wouldn't it? But we recognise that all four don't always exist at the same time. And then for others, it's pursuing health equity. Now that's a really big buzz term, and I think that's really valuable. So how are we going to do it? This is maximising involvement of the general practice team when addressing quality improvement in QOF. It would be churlish for me to think that we could present all of this information in detail, in enough detail, in less than an hour. So I would use this as the main summary slide. Like I mentioned, we have produced a series of other resources which are available on the RCGP website that will take you through how to run a project. There's plenty of resources outside of the college website, but I like this slide because we've tried to put it in maybe 8 points in one. So the basic steps here, they're far from exhaustive, but it boils down into roughly 3 stages. And that's maybe stage 1, where you said diagnosis, which includes get everybody on board. If you can work out what works in your practice or in your PCN and knowing where you stand, then that's when you can start making inroads. If you don't know where you are and you haven't got a team around you, it's not really going to work. Establish what's feasible, because there are some really detailed and complex ideas and changes. And if you look at maybe what's worked in other parts of the world or other parts of the UK in neighbouring practices, you may not be able to deliver on that because you lack the resource, you lack the staff member, you lack the patient population to replicate what somebody else has done. So work out what's feasible for you. And then the third point we've said is small changes. And that's really crucial because wide sweeping changes are very unlikely to work. The majority of huge changes will fail. So we're really targeting on making small changes and monitoring how they've how they've come across, whether it's worked or not. So quality improvement is not about jargon. It's not about foreign concepts. It doesn't need guru status. It doesn't need an in-depth knowledge. It doesn't need textbooks, even though probably there are people in your CCG, probably in your practice, probably in the PCN that have got this already. And maybe this is a lever to sort of open up and say, right, okay, what have we got here amongst our team? What do we need? So, and that takes us to stakeholder mapping.
Okay, I'll take over there. And this is the crucial part of quality improvement. If there's anything that you can take home from this webinar, it's about how to really work with your team to understand what is the problem and what are the solutions in small scale steps. When you start talking to people, you will be inundated with a number of frustrations, pinch points that really upset people. They're dealing with things that happen over and over again. We all know that there isn't capacity or additional resource in primary care at the moment. Stakeholder mapping is all about identifying all of the people who can do a little bit to help move things forward and build capacity. Ideally, you'll be wanting to get a range of different people with different interests and capabilities. So you will be looking for people who have quality improvement skills in terms of who can diagnose the problem, who is it that works in the data, who understands the data that's there already, who works with the patients, who talks to the patients about their concerns. And then it's working with them, all those people, to identify who's interested and who holds the purse strings to be able to focus on a very small area of that change that might be feasible, that could benefit both, hopefully, staff and patients. It's about trying to build your capabilities. Don't worry about the seniority of people. In some of the projects I've worked on, healthcare assistants have had really big impacts, and because they think outside the box and they're not ingrained in terms of how things have always been done. People new to training, and some of the new roles that we've got in primary care might add to your capacity as well. Primary care managers the practice managers are the key to understanding data. But there's other members of staff like your physician associates, healthcare assistants, physios, associated pharmacists, whether you've got a practice pharmacist or one linked to the practice. There's lots of roles that might help you think out with the box to think about quality improvement as a team sport. Lorna, is there anything that you'd like to add to this?
I would echo Liz that we just need to listen to everybody in the practice team. It's so important to get everybody's perspective, and also for your staff to feel empowered enough to be able to come to you with a solution, a potential solution to a problem, rather than just moaning about something that they feel they can't change and they're frustrated with. So, we have new roles in practice now, not just clinical roles, but you've got, care navigators, some senior admin members in every team at the moment who might be involved in roles that previously were GP roles, for example, your workflow, your document management. They are seeing it from a different perspective. And sometimes, it is a case of, well, we were told to do this and we've just always done it that way. And if they understand that, though, there is a team that are willing to listen to them within the practice, or just one person who will listen and will see that as an opportunity for quality improvement, and reviewing the system or the process to make it a better task for them to do, to make it more efficient. As Mike said, just they'll enjoy it more. You can get your team on board, and there's so many people in the wider team now in primary care. It doesn't just have to be GPs and practice managers, it can be everybody doing this.
And I think that's the beauty of the QOF QI concept, is that it's making people think as well that you can work with neighbouring practices as well. You're not on your own, so that even if you're just beginning, you can look for other practices that are maybe a little bit further on, or have similar problems, or who have developed similar solutions. So you can use and abuse what's already been produced. You don't need to start from the beginning. So on that note, we'll pass over to Mike for the next slide.
Yeah, thanks, Liz. I just got the news just in newsflash, we've got 27 people responded, and we've got a big range actually. I'd reckon probably half of the people, maybe just under half, are GPs. We've got partners, we've got STs, we've got salary GPs. We've also got pharmacy technicians, pharmacists, practice managers, practice nurses. We have a data quality manager. So thanks everybody for engaging and for typing in. We've got a QOF manager, a management intern. So, you know, hopefully the people involved in quality improvement going forward are going to be plucked from this cohort. Obviously, it's probably a self-selecting group of people who are here today, but maybe those people who aren't in the same practices here can go back to their own practices and point this out and say, well, look, these are the sorts of people that are doing this elsewhere. I'd also like to just sort of say that in terms of your stakeholder mapping, don't forget your third sector partners like charities. So this year specifically, and I know I'm going to miss loads of people out, but you're thinking, you know, Cancer Research UK, you're thinking Macmillan, who all have sort of GP or practice leads or practice advisors. You've got Joe's Cervical Trust, and then for the learning disability side, you've got Mind, you've got MenCap, and then don't forget the local cancer alliances, people you probably may have never spoken to, don't know exist, not really sure who your local cancer alliance is potentially, but they can give you tons of support, possibly free up some help, potentially, and certainly help you with your data collection. I'm absolutely, I've been 100% reassured that cancer alliances are ideal for that. And then probably the people that we haven't intentionally missed them out, we left them to the end here. Don't forget the patients. Try to bring your patients in as early as possible to do the ideas generation with you, to learn about what the problem is, to advise you on what issues they're having with the practice. You probably already know, but I almost guarantee they will tell you something you don't know. So whether that's your PPG or whether you choose to use a different cohort based on the improvement project you're looking at, I would wholeheartedly say start with the patients. So thank you. Yeah. So next step I'd say is, well, still part of the first element. Once you've got your team together, once you know who you're going to work with, ideally you've got somebody who's going to lead on this quality improvement project. How are you going to work out what the problems are? How are you going to diagnose your frustrations, diagnose your bottlenecks, look at your constraints? So one way to do it, and there are loads of ways to do this, I suppose, are to look at a recent clinical audit on the topic that you want to improve upon. People's eyes roll back when they think about audit, but we know they're essential for CQC. We know they're often very good for, well, they're brilliant for improving practice, full stop. Significant event analysis is crucial, particularly with perhaps this year's QOF with the cancer, also with the LD, and hopefully there will be for the future modules too. And then there are a range of different QI tools, you would say like a level above, a whole different range, which we won't go into today because that's not the core message today. We're not teaching you all the tools today, but we can certainly signpost you and show you where the other ones are, fishbone diagrams and the likes. But the one which we've always talked about, the one we always bring it back to, is the simple process mapping. I'd like to say hands up who's not done this before, or hands up who doesn't know what this concept is. I won't do that. I'm going to assume that people have got an idea what this is. And in front of you is a real one that happened not too long ago in one of our practices. I won't say whose. And just to sort of, I've only just put it on the one slide rather than add lots of different slides. But this is about patients and when they want their methotrexate. So by and large, patients will, well, I don't know, it depends on which practice you're in. Most practices will request online, or some patients will hand slips in, some patients will walk into the practice and ask the receptionist, some patients will use the email address, some patients will go via the pharmacy. So there's at least 5, possibly 6 different routes in for patients saying, I want it and I need it. But we know that not every patient has had their monitoring blood, so it's not safe to prescribe this for every patient. So the pink line there, for instance, and this practice wasn't perfect in the first instance. So the patient submits an online request for methotrexate, substitute that for any of the other DMARDs or anything that needs monitoring. So it automatically gets registered on EMIS or System 1. And then if the clinicians are doing the workflow, then they have to check the blood test to make sure the monitoring's been done. So if it has been done, brilliant, they can prescribe, look at the top. If it hasn't been done, well, what do you do? So in this practice, the clinician then opts to write the blood form, and then the clinician then uses Accurix or whichever texting system to contact the patient to say, right, now you need your blood form, there's going to be a delay, we can't do it, this just reminding you about safety. So you may say, well, that doesn't happen in our practice, we've got a great system, brilliant, fantastic. We're just going to assume that various systems aren't as, not every system is perfect at this stage. The orange ones, I guess, so that's slightly different. If a patient comes in and requests it by hand, then the receptionist at some point during the day puts it in a tray for the prescribing clerk, which then takes X hours to get to the prescribing clerk. They then check the blood tests. They then either add it to System 1 or EMIS. And so you can see what's on there. And then the yellow or the light green is a different route. And then there's a few green post-it notes there. And they are some of the changes that were made in this practice in order to streamline things, in order to make things more robust, in order to reduce waste, reduce duplication, reduce clinician time. So rather than use clinician time, use a dedicated, trained up prescribing clerk's time instead. This practice only had one prescribing clerk, so they elected to train up another prescribing clerk. So there was always two, or I think there's three in the end. So you can do this. Anybody can do this. It just takes some post-its. They don't need to be different coloured. And there's lots out there on Google or online to sort of go through the rigor about how to do process mapping. But this is one way to work out what's going wrong, what's causing patient complaint, what's compromising patient safety, what's making us stay late at work at night. And then you can just use this. So it doesn't need to be one thing. You can use a whole range of ideas. Thank you, Joe. Could you flip to the next slide?
Okay, thanks. Yes, and I mean, process evaluation examples just give you the flexibility to be able to move all those different sheets around. They're just one tool for displaying the data that you're getting from talking to people, which makes them valuable. The next stage, once you've talked to people about what the particular issues might be, is that you start to move on to actually using different data that you have within the practice and about your practice to actually explore how much of a problem it actually is. Because when you talk to everyone, they will talk about different areas that they personally find problematic. Not everybody will have a shared opinion of that. And what you're looking to do is to try and make sure that there is actually still room for improvement. And you want to be able to make that as simple for yourself as possible. So that might be by looking at routine data. Now, we all know that there's often room for improvement in the routine data sources. Sometimes they're not quite as accurate. Sometimes they're not measuring the kind of data, the outcomes that ideally you would like to see. But wherever possible, explore whether there's externally routinely collected data that your practice is already submitting, things like Public Health England's fingertips website or national audit data that you can start with before you start designing new searches and creating more workload and creating bespoke searches. Once you get a handle on where your practice is in terms of its baseline data, you can understand where there is room for improvement and start to think about how much room for improvement would be feasible when you're creating your smart aims. Internal collected data will provide a better level of detail. It will be more accurate, and you can tailor the search for the particular patient groups or staff groups that you're interested in. It's really important to see this data as a starting point and to try and make it as small as possible, because you don't want to get overwhelmed with large numbers of patients who require lots to do. what you're looking to do is use your baseline data to identify a few patients or a few members of staff that you can start small with, explore whether you change ideas that you have are relevant and acceptable and feasible before you go to scale. So I'll just pass over to Lorna, who might have some ideas for how she's used this types of data in her practice.
Thanks, Liz. For those of you who are working in general practice, you know how busy we are, and we're always chasing our tails. And it's, from my experience, usually something has gone wrong, or we've received data, or we've looked at our data and it's showing, you know, that we're an outlier in some way. So that's usually how we've identified, you know, where we need to make the improvement. Liz is right. You want to look for things, you know, small changes, because if you try to make too many changes all at once, and then it doesn't work, it's quite hard to unpick where, you know, what hasn't gone wrong and how much impact that had. So doing things, you know, one step at a time is really essential to understanding, you know, is the improvement, you know, the outcome you're expecting or not? And if it isn't, you know, you only have to go back one step then to look to change things again.
Yeah.
So we've done this using the fingertips, and also Arden searches is another really good tool to be able to use within your own practice. But there's lots of information that you can use, and you know, GP survey is another one. You'll get a real feeling for, you know, are your patients satisfied with your service, and if they're not, what areas is that dissatisfaction, you know, the highest. And you know, you can find often there's really quick wins to targeting something, you know, that it doesn't take a big change to have a big impact on your patients. Yeah. And then there'll be a knock-on effect there to your staff as well, because if your staff can see that satisfaction is increasing, then their job satisfaction will increase as well. So there's lots of different areas within the baseline data that you can use. Your practice manager will have access to an awful lot of baseline data, and they'll be aware of it because it's used for intelligent monitoring data for the CQC. But just within your own practice as well, you know, you'll be running searches all the time. Your PCN will start to be running searches now. And certainly if you're using a tool like Arden's, you know, you have a lot of information to hand very quickly that you can start to look at.
Yeah. And just remember as well, with the baseline data, those data will relate to maybe the processes of care or the outcomes of care that you're interested in that are further down the line. But when you're looking at quality improvement, you're also trying to understand whether other types of data change along the way. So, for example, you might look at your staff awareness of what needs to happen and do quick follow-up, just informal conversations in the corridor with people about, has their awareness changed? Has their knowledge changed? Has their confidence changed? Has their skill set changed? So that you can explore this, so that you can begin to understand whether there's signals that patient outcomes and process of care will change further down the line. And it's just breaking it down into smaller, more manageable pieces of data that you can understand and work with on a day-to-day basis. Okay, we'll move on to the next slide. Okay, so in this slide, we just want to share with you some of the things that we think, the types of interventions that we know from wider evidence that are more likely to work and less likely to work. It seems, you know, there's one of the things that's maybe a blessing with patients doing more video consultations is that they're not exposed to the waiting room. However, we know that now there's not that option for poster presentations to be able to alert patients to work that's going on in the practice. Or in waiting rooms, you'll know in yourself, in consulting rooms, in reception areas, you're overwhelmed with posters. It's some people talk about it being wardrobe furniture. It just doesn't make it easy to find the information that you're looking for. So lots of posters don't necessarily work and they're not necessarily going to be seen in the current context. You might laugh that lecture style presentations, didactic ones like this, where there's no interaction or very limited interaction, are less effective. So I hope we've not sent you to sleep so far. ad hoc promotion without credible evidence. Often, you know, for example, some of the data sets we've referred back to, people can be resistant to change because they think that those data sets are outdated or not accurate or not coded properly. So sometimes you need to think about how persuasive you can be. And overly complex interventions where you try and throw the kitchen sink at a problem before really paring down what is the smallest thing we can try to understand whether it's effective. So what we want you to do is just to try and talk to people about what might work. Map the barriers to potential solutions. So we all get excited about certain types of interventions. Clinical audit is one of mine, but it's not everybody's bag. But try and think outside the box. Sometimes it doesn't have to be an evidence-based intervention. One of my students tagged on medication reviews to flu vaccinations, which worked really well. So think outside the box, think small, select what you're trying to change, whether it's awareness or skills training or whatever it might be. Look in the resources for other existing interventions wherever you can. Try not to build additional data sets, questionnaires and the like. Just think about what's needed for the people that you are working with, what already is out there that you can adapt or adopt before you start producing new interventions. And hopefully that'll help you to go much further, much more quickly. Okay, if we move to the next slide. Okay, so the next slide is just about helping you. It's not necessarily a tool that you have to use formally, but it's always there in the back of your mind. It's just thinking about how much benefit do you expect to get from implementing a change versus how much effort and how much resources that it's needed. These matrices take a little bit of time for you to get your bearings with which quadrant refers to which thing, but ideally you're looking for interventions that will really have high chance of success, effort ratio needed. You want to avoid things that require additional people, additional resources, wherever possible. And you need to think about taking things out of the system before you think about adding in new interventions that take over people's time and resources. Think about how things can be done easier and more simply, and you'll be on to quick wins. Okay, if we move on to the next slide. Back to you, Mike.
Yeah, thanks. I was just thinking about what's feasible and doing small things to, quick wins, as you say, low-hanging fruit. So feasibility, I think, really comes again with just grabbing ideas and sort of allowing everybody to speak and to provide their own opinion on what's going on. So, for instance, in our practice, we were relatively late to adopt one of the excellent new technologies that texts patients, and it has all these newfangled bits and bobs onto it. And so we then ended up writing our own templates that we would send out alongside the flu vaccination invitations. So we were able to utilize that to ask about something else at the same time. And then when patients have started coming in for their flu vaccinations, we agreed that we would pre-screen who was coming in, the ones that we knew were coming in, and were able to sort of just get a bit, address some of their health issues once they were in, sort of on an ad hoc basis. Patients were on the whole relatively, they were very, very, they were up for it. They were happy to get a bit of bonus extra primary care time that they weren't expecting. A few had to dash off, of course. So in terms of the final part, which is making the change, well, we need to make the changes, but we also need to know that the changes that we're making are beneficial. And how do we do that? Well, we need to be able to measure those changes. So you may or may not have seen this already. On the right-hand side of this page is something called the model for improvement. And it is, there's plenty of words there, but you could say, what are we trying to accomplish? Well, we're trying to achieve an aim. And as you go through the module, as you go through the guidance for the QOF QI this year, you'll see it's presented in that sort of fashion: aims, measurements, changes. So how do you know you're going to make a change? Well, you do need to be able to measure things. And so that's really crucial when you determined your aim, and it needs to be a smart aim. So it does need to be achievable, and it does need to be timely, and it does need to be measurable and the likes. You need to think about, well, how are we going to know? How will we measure this? So you need to be quite really clear about that. And the people involved in the measuring need to be really clear about what they need to do and when they need to do it and how they're going to report it and who to. So there is some real clarity that needs deciding upon before, but that's probably, that's the planning stage. It's relatively straightforward once you have a QI team or once you have a project aim in mind. So the route that a lot of people take routinely is they've decided on their change and they just implement the change. And from previous experience and from hearing from various people in different PCNs, even before this QI work was integrated into QOF, you would find that 4 or 5 different good quality change ideas were all implemented at the same time. And you'd find that because of this big injection of energy and time, that often results did improve. They may not have continued to improve. There may not have been any sustainability because that wasn't maybe thought through in advance. And in many cases it was. But what we would recommend is, once you decided on what changes you may wish to implement, then try to introduce them one at a time, and then monitor the response. You've got years to do this. We have months before the end of this fiscal year, of course, but the QOF QI is going to go on for a good few years. So one example we just wanted to address, because obviously we've got the cancer QOF, was that of cervical screening. So one practice wanted to create an aim, which was over the next 10 months, try to increase their total uptake of smears by 8% to reach the national average. They actually said they wanted to beat it by an extra few percent as well. And so they thought about, how are we going to know what changes we'll do are going to make a difference? Well, so they created these searches. These searches are already on the computer. How many people have been screened within the specified period? So that's 3 years or 5 years. What proportion of patients have had a first, second, or third reminder letter? Easily searchable. What proportion of patients had been sent text messages the day before? And then, as Liz said, actually, what was the confidence level? What are people thinking? What are clinicians thinking in terms of confidence in having conversations with patients about screening? So the changes that were implemented in this case, and I'm going to show you another slide in just in 1 second, were, in fact, Joe, if you wouldn't mind going to the next slide. So once you've decided what your aim is, how you're going to measure your the success, and once you've decided upon your changes, you may as well just go for it, just run for it. And in terms of measurement, well, you can either use a pencil and a piece of paper and a piece of A4, and just, in the example I've used, you're looking at how many smears were done over how many weeks. Now this is part truth, but part I've accentuated some of the positives and minimized some of the negatives. But a practice did undertake these 4 changes for cervical smears last year. So if you look at it, and if you're pretty handy using an Excel spreadsheet, as long as you just put, the numbers of your weeks in week 1 and your numbers of smears in column 1, number of smears in column 2, and then you just press chart, it will turn it into something like this. So you can either do it by hand. Your team, once they can see results, do respond to that. And some practices put these improvement journeys in full view of patients. Unfortunately, there's not many patients in practices now, but stick it up on a patient wall if it's all anonymized, and patients can see how they're doing, how the practice is doing as well. So the changes that have happened here, so the changes happened every 8 weeks. Change 1 was implemented when text messages were sent on the day prior to appointment to remind the woman to attend. Change 2, and as you can see there, the average number of smears taken per week went up after that change. Change 2 was leaflets in different languages were placed in the waiting room for the benefit of the practices hard to reach cohort. So that didn't really make much of a difference if you were to just draw an average line through there. Change 3 was that the rota was changed, and that allowed 2 late afternoons and evenings per week, which were previously not allocated to a clinician that could perform smears. So increased access happened there, and that actually did improve the average numbers taken per week. And then change number 4, which also made a mild difference as well, was opportunistic screening. So all the clinicians agreed to consider opportunistic screening. And I know that's not really feasible everywhere, but that it did include those that women just said, right, I can get this done now. Is anybody available to do this? Yes. And that in that practice actually did make a difference. So these are called Runcharts basically, and you can just plot numbers on. Thanks, Joe.
Okay, and with these Runcharts, the Institute for Healthcare Improvement is another source that has a template that you can just plug the numbers into if you're starting off new, which can be very useful when you're first starting off. The thing about Runcharts is that we start with one very small cycle. And what we would do is we start at the bottom of this diagram, and you start as small as you can. A couple of patients, a couple of members of staff, just test things out. Decide whether you think you're having an improvement or whether there's any unintended consequences if it's taken too much time or resources away from something else and not having benefit. Then you make your decision about whether you'll adopt that change, try and adapt it a bit more to make if it's looking promising but hasn't shown benefit yet, or abandon and start again, thinking by talking to people about what another more appropriate, more feasible, more effective solution might be. This diagram is a little bit confusing because it does suggest that there's linear changes, but this cycle is the first really important one, and you might not go beyond that. The next stage, though, is if you have decided to adopt the change, is then to broaden it out, work with a bit of a larger group of patients or a slightly different patient cohort or other members of staff, and try again. Think about what works. Think about whether it's working for other different types of patients or providers. Keep refining, keep moving forward, keep taking small steps. Try and focus on improvements and thinking about where you can. Don't get bombarded with thinking about having one effective intervention and having to make sure it's evidence-based before you start. Just start with the hunches that you think is intuitive to your setting. Think about what's already there, evaluate whether it can work for you, and then move forward. And don't get too het up about thinking that you have to take everything to scale immediately. Just start and get your quick wins and feel really good about what you're doing in your practice for you and your patients. Okay, back to you, Mike.
Thanks, Liz. Thanks. So we reach our summary. So I think hopefully we've addressed our aims at the beginning. We've talked to you about some of the benefits, the range of benefits of quality improvement. We've acknowledged that time is a limitation. It really is, and it must feel like this may be additional work, but there are benefits to getting this right, or for trying it out and then learning and learning and learning. We've talked about a few simple tools to help support your first or your next quality improvement project. We haven't really talked about sustainability yet, but we've touched upon it. But we do have resources to address that as well. And that's often the thing that we sort of see in practices that either don't have the resource or whether the changes haven't been embedded fully. And we'll talk about those resources right at the very end. So I hope we've addressed how you can make a start on the work, how you can set up your team, the importance of working out who you can entrust to help you. We talked about aims, talked about measurement criteria. We talked about what success will look like. And also, an element of how to sustain new practice. What we want to do now is try to address some questions. But I have been hearing from Joe. So Joe works at the college and he's been hosting this in the background. And we've been answering questions as we go. which hasn't left us with many left. So if you do have any, please feel free to ask them now. We've got only about 7 or 8 minutes left, so there's a few things I do want to say at the end, but I want to say thanks in particular to Lorna. And wonder, just Lorna, you know, you work with the college, but you've been embarking on quality improvement for a few years now. So I just want to know, I won't say yes or no, but has it improved your practice, and how have doing these improvement projects improved the practice? What are the benefits that it's shown to your team or your patients?
The benefits, the first benefit at the moment is any change that you can make that improves either the service for patients or improves a process or system for staff means that you're more likely to retain your staff, and they'll feel listened to within the practice. And also getting involved in things like QI, you know, gives them that bit of ownership, and certainly from a staff retention point of view, that's a great thing. We have often, as I said earlier, had to deal with an issue because something went wrong within practice, whether it's through a significant event or a complaint or just areas within your patient survey, you know, that you haven't performed so well in. And, you know, we tackle things because there's a problem, but when you begin to tackle it and you start to get ideas from other members of the team, you don't just solve the problem, you know, you take things even further than that, and actually it can end up something that you're really proud of, and seeing the difference in the change from start to finish, albeit very small steps to get there, actually can bring the team closer together. And, you know, we've done quite a few things that when I was asked to sit on this panel, you know, I actually thought, well, I can't really think of anything from QI, but when you start to look at the areas that you have tackled, you know, we're constantly in change, we're in flux all the time in primary care. Most of it is forced upon us. We don't really get a choice in that. So when there's something that, you know, you can choose to tackle, and it's something that's important to you because it's important to your patients or it's important to members of your team, when you get to take something on and actually you see the benefits and you see them quite quickly, and you can see everyone buying into that, you know, it's a great feeling. And also, you know, from a manager point of view, you can save quite a lot of money, you can save a lot of time. It's nice to go to meetings where data is shared in your PCN or your CCG, and actually, you know, you're up there rather than down here because you've looked at something and you've spent a bit of time on it. So it's always a good thing to do it. It's finding the reason you're going to do it in the first place. And there'll be hundreds of things within your practice, and if you don't have any ideas, trust me, different members of your team will. Sometimes it's good to speak to the people that are the newest members of your team, particularly if they've come from somewhere else in the NHS, because we don't need to reinvent the wheel. If there's something that's worked in another practice or in another area, you know, if they've come from a hospital background, listen to those ideas. And then when you do something and it has a positive impact, then share that with your PCN, share that with other practices that you network with, because, you know, we're always looking for these quick wins and ways that we can improve on things.
Yeah, Lorna, your practice looked at bowel screening rate, didn't they? And trying to improve that.
Yeah, so bowel screening is something that, you know, we were struggling with within the practice, and it's one of those things that, you know, a lot of patients aren't comfortable doing. And initially, you know, we were just kind of following the process, the motions, if you will, as far as sending out a recall, sending out an invitation. No, they didn't have it. So actually we used a process map system, had a look at how we could improve that, where we could have more contact with the patient and discuss some of those concerns, and, you know, who would be the best people to do that. We used our cancer champion to do that, who was really keen and really motivated, along with you know, some support from the local Cancer Alliance, and made sure that our cancer champion had enough training to feel that she was able to answer some questions, and if she couldn't, who in the team she could escalate those those queries too for patients, and just having those chats with them and reassuring them and explaining to them, look, this is the process and this is all you have to do, and it's really important. Actually, did see positive benefits within our practice for for our uptake rates. The important thing though is when you do this, and you'll often find either the staff turnover, or you think a system's working quite well, so you don't put as much focus on it. Sometimes you do need to revisit these things, and the Runchart is a great way of doing that, because you can start to see if things fall off again and it just needs a little bit more focus, or whether once you're doing something to a level and you want to improve it further, how far you can take it next. So but yeah, your screening ones, there's an awful lot of information out there, and you can get all your baseline data quite easily for those, and there is a lot of help out there from Cancer Alliances, and your local Macmillan's team or hospice teams are always willing to come in and support your team and help with training and such. So it's a good thing to have a go at. Thanks,
Lorna. No, you're right, and we didn't even talk about, you also concentrated on looking at percentage of 2-week wait referrals, didn't you, that came back with confirmed.
So that was one that in one of the QOF QI meetings that we hold with our PCN, that wasn't our practice, that was one of our neighbouring practices that had looked at that first and decided on the back of practices being aware that maybe patients through COVID hadn't been coming in the same way, with the worries about suspected cancer, and decided to look at their referral rates under the 2-week rule to see whether they were significantly lower than previously. And then they took that one step further and looked at the individual clinicians and what percentage of 2-week rule referrals per clinician were came back, positive. So, and then looked at aligning those, and what, again, there's so much national data out there, and where you should sit and benchmark that. They presented their audit to our PCN in one of our strategic MDT meetings, and we thought that was a really good idea, and we decided to take that back to our practice and do the same. And now as a network, it's not just even individual practices looking at this, we can look at it as a network and see, do we have outliers, and if we do we need to give them more training? Do we have anyone in the network who actually seems to maybe be a clinical GP cancer champion and can support the other GPs with how to do that? So it's worked really well for us.
Brilliant. Thank you. I recognise we're approaching the hour mark. I've got lots of other questions, but I'm not going to be able to get around to them. Sorry. So to everybody out there, we are planning to send out an email with a link with a short evaluation questionnaire. So that helps us understand if we've got the content right and what we can do going forward to tailor things to the needs of you, our audience. So please do complete and return this. This information is greatly appreciated. If you do want to dig a bit deeper, and I know we've touched upon lots of elements here, there's lots of QOF-related, QOF-specific QI-related resources available. There's some podcasts. We have undertaken podcasts on both early cancer diagnosis and care of those with learning disabilities. And they've gone live, and you can find them wherever you get your podcasts by searching for RCGP. And they're basically a whistle-stop discussion of the modules. There's a webinar playlist. So we've delivered a webinar on QI at the PCN level. We didn't go into PCNs much today, and one of each of this year's modules. So these are available on the RCGP YouTube channel, and a video of this session will be added in the next week. And finally, there is the QOF QI page on the RCGP website, which is rcgp.org.uk/QOF QI for other resources, including top tips, including case summaries, including PCN guidance, visual summaries of the modules, and links for all of these will be included in the evaluation form, which Joe will send shortly after the meeting finishes. So I'd like to finish by thanking Lorna and thanking Liz for your time once again and for making the content so engaging. I'd like to thank our colleagues, past and present, who've worked on the college's QOF QI programme. And finally, I'd like to thank you, the audience, for joining us. We are looking forward to seeing you again soon. Goodbye.